tissue death. So how do we do this technique? We mentioned that it's a minimally invasive. How can it be? Well, we first do an ultrasound visualization of the prostate. Then we place temperature probes and cryoprobes as determined by computerized treatment planning. Then we activate the cryoprobes which leads to ice ball formation under close real-time ultrasonic monitoring. And the goal of the treatment is to create a lethal ice ball within the confines of the prostate, without damaging adjacent structures such as the sphincter, rectum, and the urethra. So we need tools to do this, and this is the horse, or what they call it. This is what it does. Alan Chung's company's machine, which I think is an amazing piece of art and science. It's one console that includes planning, ultrasound, and treatment system all in one. In other words, with this machine you can see the prostate on top. You can do your treatment planning by using the console. And then inside of this machine there are the big heavy pressure machines that will push the gas at 5,600 psi to get through those tiny needles and create the freezing. And then the tool that we use is this probe, the cryoprobes, which is 2.4 millimeters in diameter. It's vacuum insulated with an elliptical ice ball that forms at the end of it, as you see, when we activate the argon gas. So this is the ultrasound picture of the prostate before we have done anything. That's how we start. We first look at the prostate. We measure it. We do what we call volume studies, because the machine needs to know the three-dimensional image of this prostate so that it decides how many needles to put, where to put them, etc. And then this is, it gives us this treatment plan. It tells us you have to put 6 probes, the larger dots, in, and shows where to put them. And then the little blue dots are the temperature sensors that we have to put next to vital structures to monitor their temperature and make sure that the ice doesn't get too close to those structures, not to damage them, such as the external sphincter, the rectum, the urethra, throughout the full length of the prostate until we reach the bladder area. And then once we have put our cryoprobes in place and we're happy with their depth placement, we activate the gas. And the result is the formation of 6 confluent ice balls that will fill out the whole space occupied by prostatic parenchyma, destroying everything in its path. This is a little animation of the procedure. The prostate is identified. Ultrasound probe is inserted to monitor the treatment. And then we start inserting the various probes that we need, the cryoprobes and the temperature probes. And while in place, we turn the gas on, and then we start forming those ice balls. And of course we can choose the size of the ice ball depending on the size of because our probes are manufactured such that you can go from 4 to 5.5 centimeter size of the ice. So you do it twice and then you're done. It takes about 1 hour. So this is how the prostate was before the cryo. And this is in the middle of the freeze. It disappears from the screen because when ice replaces it, the shadowing will hide the prostate, and that tells you that you have reached down to the rectal wall, but not beyond it. And you have covered the whole area where the prostate used to be, and hopefully a successful treatment. So what are the clinical outcomes? I think the landmark study of cryoablation was a paper by Aaron Katz and Rucastle from Colombia, who as early as in 2003 reported on their initial experiences with cryoablation, which has changed very little. I mean, there are new studies. One problem with cryo that there are no prospective studies. You cannot compare cryo head-to-head to surgery or to radiation because there are no such studies. These are all clinically. What has happened is that the community has taken over more cryoablation much more warmly than academic centers for whatever reason, because they have residents, they have to teach them surgery maybe. But the community has been more upfront and more welcoming of this new technology. So what they did, they did a comparative analysis based on all studies of primary cancer therapies, reporting rates of 5-year biochemical disease-free survival. And they reviewed all published papers over a period of 10 years regarding cryoablation, 1992 to 2002. And they analyzed the results based on low, moderate, or high-risk patients. And the study looks for trends. It's not designed for conclusive comparison of the different therapies. Low risk was defined as stage T1 or T2A, Gleason score 6 or less, PSA less than 10. Dr. Greenberger's patients, basically. The low risk. The moderate risk defined as stage greater than T2A, Gleason score greater than 6, and PSA greater than 10. And then the high risk was defined as 2 or more of stage greater than T2A, Gleason score bigger than 6, and PSA more than 10, 2 of these. And this is the findings of the BDFSs for various treatment modalities. For low-risk disease, surgery was 76 to 98%. Cryo was not that bad, 60 to 92. Brachytherapy was 78 to 89. 3D conformal was about the same, and the external beam radiation was in the 80s. When we moved to moderate risk, the numbers started changing. Surgery numbers seem to go a little south. Cryo numbers seem to be holding, and then radiation is a wider range. And then for high-risk disease, and we're talking about advanced T3s or whatever, surgery really does poorly compared to cryo, which still has an 89% maximum BDFS. It's a wide range, but still they managed to reach that range. And then brachytherapy, I'm surprised to see it was 0% up to 65%. So they also noted a lower positive biopsy rate with cryo than observed with radiation therapy. High quality of life scores for cryo because of significantly less short and long-term morbidity compared to the other modalities. There was, however, significant erectile function impairment. It improved with time in some patients with resolution of cryo-induced neurovascular insult, neuropraxia. The conclusion at that time was that prostate cryoablation is expanding rapidly because it is safe and efficient. It should be offered as a treatment option for patients presenting with localized prostate cancer. And recent literature evidence from Hahnemann, not Hahnemann, the big Allegheny Hospital, which is one of the centers where cryo was really put in use. They have 7 to 10 year data showing that cryoablation is safe and effective in patients with radiation therapy failures. Cryoablation is effective in the treatment of the high-risk patients, especially grade 8s, grade 10s I have done. And a 10-year retrospective data on 249 patients that showed a BDFS of 77% and a prostate cancer-specific survival rate of 98%. The American Urological Association has been on the sidelines when it came to cryo until 2008, when they came up with a best practice policy consensus statement on cryosurgery for the treatment of localized prostate cancer. It's a long thing, but they say that it's a viable option for treatment. And it also says that high-risk patients may require multimodal therapy, which we do sometimes, adjuvant hormone therapy. And it's also great, in my experience at least, for salvage cryosurgery. I have several patients who had failed radiation walking around with PSA of 0, because in those patients you're treating small amounts of recurrence and they do very well. They're more challenging, but they work. The summary is cryoablation is indicated for the treatment of all stages of primary prostate cancer except for T4. Salvage cryoablation is safe and effective. 7 to 10 year clinical outcomes of cryo are comparable to other treatment modalities. Cryo seems to be more effective in moderate and high-risk patients. Minimal invasiveness, low morbidity, quick recovery, and favorable clinical outcomes make cryoablation a viable option for the treatment of both primary and radioresistant prostate cancer. This ends my formal talk. My take on cryo, I have done about 150, and most of it, these have been leftovers from when doctors didn't want them to have surgery or they didn't want radiation. So a lot of my patients that come to me are high risk and advanced. And my thinking has changed over time that, you know, we as doctors are programmed or conditioned to say, you have to cure cancer, you know. I think that's a very lofty statement. I say I want to provide my patients with long-term local control. Because in 30 years of practice, I have noticed that prostate cancer patients don't die from a little bone metastasis or because they have a little lymphadenopathy. They die from complications created by local extension of the disease. Typically, invasions into the bladder with hematuria and, you know, terrible pain. Rectal invasion can happen, but most importantly, urethral obstruction by this cancer growing and occluding the ureters. And most of prostate cancer patients die from renal failure, and those are very, very painful deaths. In my cryo patients, I still have to see one who progressed to uremia. Some of them, maybe their PSA goes up a little bit. They're 82 already, and I can guarantee them that they will never die from prostate cancer. So I think it has its place. It's maybe doesn't cure as well as other techniques. I'm not convinced about that. But I think it provides a tremendous benefit to the patient, who is a high-risk patient, elderly patient, in preventing those unsavory complications that are bound to happen with time, with or without hormone ablation therapy. Because I have seen patients who, they fail the hormone therapy, and the cancer comes back with a vengeance. The Gleason 6 comes back as Gleason 8, Gleason 9, and it's only a matter of time before the cancer will take over. That's when you have to interfere.